effects. And then you can see kind of the bottom, the negative side effects that somebody might experience if they're taking it or maybe overindulging in some of these drugs. So sorry, I'm gonna let you guys do the presenting.
Okay, I think this one's mine. So it's mainly shown that it's started to be used for PTSD, mostly just for severe cases of PTSD. And that's only been used when all of the other treatment methods have failed. And it has shown that it's been more effective when it's also combined with psychotherapy. Um, and then I also just found a study there that shows the effects of psychotherapy and MDMA together and how it has advantages over the current therapies that are being used. And then also just, I guess, kind of along with PTSD, it also is helpful for severe traumas.
Yeah, so it's interesting to note that this is finding, I think, more use in the clinical field, especially in the field of psychology and psychotherapy. I think it's worth also noting that although it isn't relevant exactly to MDMA, but psilocybin is also being used in a very similar way. Again, kind of just altering the state of that individual, and then through like a guided experience with a psychotherapist, some people have found these particular drugs to be very advantageous in terms of processing periods of trauma or stress. Really quickly, somebody asked a quick question, asked what causes the visual hallucinations and auras. Again, just kind of going back and thinking about the mechanism of action of MDMA, we're talking about how it's prolonging serotonergic activation. And so if we kind of pair that with what we learned when we were talking about serotonin, remember talking about how serotonin plays a role and can actually elicit auras when individuals suffer from migraines. So it's probably a very similar pathway that you're seeing activated there in terms of the hallucinations and auras development that occurs via MDMA. Again, it's activation of that serotonergic system. And again, we see that as a positive side effect in the use of MDMA. And then we kind of see the negative side effect of that when we're talking about 5-HT receptor stimulation during things like migraines. So hopefully that kind of answered your question and kind of brings it back to some, part of this discussion that we've talked about previously as well. Is this the non-present member of your group slide?
Yeah, Mackenzie's not here. I can read it. So side effects are increased heart rate and blood pressure, nausea, muscle cramping, and a few of the other more common ones are chills and sweating, and teeth clenching and anxiety.
Yeah, so this again kind of overlaps with both the positive and negative side effects. Again, it's just kind of a matter of personal kind of experience and dosage, and also kind of environmental cues as well. Not your unpresent member of your group. I can go ahead and present this if you like.
I think multiple people worked on it, but
okay,
I can read it so if you don't have to. So for tolerance, dependence, and withdrawal, for dependence, it was found that it's unlikely for it to become a serious problem due to the decrease in pleasurable or rewarding effects of the drug when used frequently. But you can have long-term tolerance from axonal degeneration and from downregulation of serotonin transporters. You can have a short-term tolerance from your desensitized receptors, and then a lack of stored serotonin in your cells.
Okay, so again, not as probably, we'll talk about tolerance and dependence today, but with MDMA, you're again not as likely to develop a long-term dependence on this.
This is something I added. I just thought it was a cool fact.
That MDMA may suppress dyskinesia associated with long-term use of L-DOPA. So again, just kind of an interesting, I guess, clinical use that individuals might not consider when they're thinking about MDMA. So that is kind of a fun additional fact. Okay, awesome. Well, good job, folks. That kind of wraps up again that part of the presentation. Are there any questions or concerns, I guess, about the MDMA information? Any additional kind of questions?
I'll just jump in for a second. I think we've probably talked about this a little bit before, but the idea that hallucinogenic substances, or at least some of them, might be useful in a psychotherapeutic realm dates back at least to the late 1960s or early 1970s. There was a substantial movement at that time to explore those ideas, which unfortunately just got deep sixed by the blockage of just about any work that was being done in the United States with respect to hallucinogens. So we've fortunately in this last decade or so been getting back into those studies a little bit, but there's a huge gap of probably 30 years or so there in which we could have learned a lot more about this than we have learned. So hopefully this will continue to be an area of exploration, because there's tremendous need for it. And, you know, I'm so thrilled that there's, you know, that it's helping at least a little bit with respect to PTSD, because the need for help there is just infinite almost. And although we often think of PTSD as associated with warfare and so on, which it is, and then that's a tremendous concern. Just about any traumatic event has the potential for producing difficulties like you see in PTSD. And since there's lots of traumas out there, there's lots of need for development in this area. So hopefully in your lifetimes in the field, we'll see some real advances coming through along these lines, because there's just a tremendous need for it. Thank you.
Yeah, it's interesting to kind of note too, there was a period of time, even in the US Army, where they were trying to investigate the effects of psychostimulants on performance of soldiers. And so, you know, I'm hearkening back to the where I did my postdoc at Edgewood. They used to do psychostimulant studies on soldiers. They would give them things like methamphetamine or, you know, LSD or whatever to actually, and then test the performance of these soldiers kind of in the field. And this is just kind of one of those almost like folklore types of things that I heard walking around the base. So it's just kind of interesting to think about how even the government kind of had their hand in investigating the effects of psychostimulants, either positive or negative, and obviously not necessarily always in the positive regard in terms of increasing the effectiveness of a soldier. Okay, so today we're just going to continue this discussion that we've been having about psychostimulants and kind of capstone it, talking about different treatments of drug addiction. What's going to be interesting, I think, about today's lecture is the fact that we're going to kind of talk about a lot of the different systems that we've discussed previously this semester, and then we'll also kind of revisit even some of the treatments that we've discussed for addiction. I think when we get to the slides about alcohol dependence, I think a lot of those drugs that we see there will probably definitely ring some bells in your minds. This first slide is just nice because it really shows you some of the, you know, the different cortical regions that are really important for addiction. We'll be defining the difference between addiction, tolerance, and again, there's, I think, a lot of nomenclature here that's important to keep very straight, so we'll make sure that we define those right at the beginning. But we'll come back and revisit this slide as well, because we'll be talking about the interconnected regions of the brain and kind of how these addiction pathways are originally kind of set, and then also kind of how they're reinforced over time. So hopefully by the end of this class, you should be familiar with things like addiction, dependence, and tolerance. We'll talk about some mechanistic classifications of drug abuse. There's a great table in here. Again, I think our textbooks do a really nice job of putting together information in tables. And I actually find tables a really great way to study because it condenses a lot of, you know, complex information to something very, you know, informative and discrete. And then lastly, be familiar with various addictive drug treatments. And so we'll talk about some drugs that are utilized in order to assist in the withdrawal wall of different drugs that are highly addictive. Okay, so again, it's very important that we kind of start by setting up our definitions and making sure that our definitions are very clear. So kind of discerning between both dependence and addiction. So when we talk about dependence, we're talking about essentially a tolerance to a specific drug. So I think of dependence as kind of a drug that upon repeated exposure, your body responds in a specific way and generates almost a new shift in homeostasis. And so because of that shift in homeostasis, once the drug is absent, you have withdrawal symptoms that occur. And again, these are very physiologically driven experiences where, again, you have constant stimulation of some type of system, receptor system, or what have you. And once that activation ceases to exist, then you have these physiological withdrawal symptoms that happen, again, because your body's almost kind of is no longer in the homeostasis that it had generated during the interaction of that drug. It's important to recognize that dependence can occur with drugs that are abused, drugs that are prescribed, because again, you're giving your body pretty consistent stimulation of a specific receptor or what have you. And so if you would omit that, it's going to cause, again, a huge shift in the physiological response of your body. The second term here that we have here is addiction. Addiction is almost a form of maladaptive memory. We're going to talk about the circuitry that essentially generates this maladaptive memory. When we talk about addiction, there are a lot of different players that are important for addiction. Addiction is more, I don't want to say a behavior, but it's a repeated reflexive activation of reward circuits. So you have this set of reward circuits that are essentially wired within the brain, and then there are these types of triggers that it can essentially enact the seeking out behavior of a specific drug. And so when we look at the different regions of the brain that are important for addiction, we'll see that there are areas that actually form memory, areas like the hippocampus. And so again, once that triggering event kind of comes to take place, you have this drug seeking behavior that can occur again and again and again. So I think of addiction maybe as a higher order kind of cognitive process, and then dependence is kind of a more at the kind of receptor cellular level dependence of the physiological response of the body. So again, just kind of keeping those two things very separate and defined, I think is important. So when we talk about dependence, dependence is a physical dependence. It's a progressive pharmacological adaptation to a drug resulting in tolerance. And we'll talk more about tolerance here in a few slides. And so an abrupt interruption leads to withdrawal syndrome. What we'll see in terms of treatments of a lot of drugs of abuse is that the best way to kind of treat this withdrawal syndrome is to do a slow tapering. And sometimes that slow tapering is with a drug that has a different kind of pharmacokinetic profile. Sometimes they just are not as addictive necessarily in kind of the way they interact with the receptor. But again, you want to do kind of a slow tapering off of that concentration that particular, physiological system is seeing. You don't want to do an immediate kind of pull off cold turkey type of response. Again, you're kind of battling with the body's homeostasis. And so if it's set at a specific homeostasis and you quickly withdraw something, it's going to throw the whole system out of response very quickly. Dependence can occur with the examples that are given here: opioids, beta blockers, antidepressants, benzodiazepines, stimulants, even those agents that are prescribed for therapeutic purposes. So for example, I just recently started taking a blood pressure medication, and it actually says on there, do not stop taking this, and you can, there will be like an immediate negative response, like it increases my rate of like heart attack and stroke, again, because you want to slowly taper off that drug exposure. So this is not itself a sign of addiction, again, because this can happen even with non-drugs of abuse. When we talk about addiction, we think of addiction, it actually develops in a minority of users. The addictive profile of different drugs kind of depends on how strongly it activates some of these pathways we'll be talking about later. When I was reading through our textbook, the percentage of addiction for THC is roughly 10%. For cocaine, it's roughly 20%, and that's over the lifetime of the user, but can lead to progressively compulsive and out of control drug use. And so again, once that reward pathway gets activated and gets reactivated, that seeker is just looking for that high again and again and again. And this doesn't necessarily just happen with drugs. It can happen with a variety of different behaviors that cause excessive release of neurotransmitters like dopamine. So, I guess physical actions such as gambling, food, all of those things that release dopamine can also lead to these addictive pathways that we're going to be talking about. There's just a strong association with the environment that's around it. Again, these are the types of triggers or cues, and we'll talk about the interaction of these environmental cues with the user, but it activates these reward circuits that becomes involuntary and with very rapid onset. So again, it's almost like these individuals are addicted to that dopamine rush, and to a certain extent, I would say that we're all probably addicted to a little bit of a dopamine rush because we all have these things in our lives that we enjoy and we seek out to recreate those behaviors, right? You see a cat or you see a baby, right? That releases dopamine in your brain. You're not necessarily addicted to looking at cats or babies per se, but it's just kind of a milder form of what we're talking about here. Again, you're just seeking out that repeated rush. So again, kind of defining the nomenclature we've been discussing here, things like sensitization and tolerance. And so here on the left side of this graph, you can see kind of a normal dose response curve that you would expect with a drug. And you can see the difference between sensitization and tolerance. And so with sensitization, you kind of have a shift to the right, which means that at lower doses, you can still get that relative effect, and that occurs. There's a greater effect seen after that initial dose. And then in the cases of tolerance, and again, you can think of, we talk about tolerance developing in things like ethanol consumption. You have to ingest a larger amount of the initial drug to get to that same level of relative effect. And so there are a lot of things that contribute to tolerance. And so probably the more clear example of that would be things like that upregulation of alcohol dehydrogenase, right? That's going to alter your tolerance to alcohol metabolism. And so you have to maybe ingest more to get the same relative effect. And so that's just one very simple example of tolerance, but there are a lot of different things that can contribute to tolerance. The other example, or the other graph that you see here, as an example of cocaine-induced changes in the CNS that causes dopamine release. And so we just talked about cocaine last Thursday. So here you can see some examples of some data. So if you look at the cocaine treatment after day one of treatment, you see that peak of dopamine release that occurs there. After day 7, you see it taper down. And then in the case of saline, you don't get that same amount of dopamine release that's apparent, as you can see here. So again, cocaine is going to cause increases amounts of dopamine release. Really, it's causing increased amounts of dopamine hang time essentially in the synapse because you're blocking that dopamine transporter. But again, causing increased activation of the dopamine receptor. So individuals who are addicted to cocaine are going to be seeking that out to, again, get that dopamine rush that's so important, especially in these addictive pathways. So there are a couple different figures that I'm going to be showing you, kind of demonstrating the pathways that are activated during addictive processes. This one is a great kind of zoom in, showing what happens at the synaptic level, but you're not necessarily losing the information of the connectivity of the different regions that are important for addictive behaviors. And so we'll look at these two regions and how they're distributed and connected to some of the larger areas of the brain as well. But obviously the ventral tegmental area, and that'll be seen as the VTA in future slides, and then the nucleus accumbens, which will probably be represented as NA. So you can see here that there are a series of both dopamine as well as GABA neurons that are represented here. So you can see here that there are different classes essentially of kind of drugs of abuse, as we'll be discussing today. You've got your class 1, which are your opioids, THC, GHB, and which activate G protein coupled receptors, and those are going to be expressed on the GABA neurons of the ventral tegmental area. And those are going to interact directly with the dopaminergic neurons. And you can see those dopaminergic neurons are also going to be activated by benzodiazepines, nicotine, ethanol, those channels, which can either inhibit or activate those dopamine cells. And then lastly, you can see these class 3 types of drugs, the cocaine, amphetamines, and ecstasy. Those are going to alter drug or neurotransmitter transport, and thus by blocking that uptake or that transport of those neurotransmitters, you prolong activation of the receptors in those synapses. So again, it's the interaction of both the VTA and nucleus accumbens that starts to kind of train in that behavioral pattern that we'll see again that gets activated periodically, and so in certain, let's say, environmental situations, once that addictive pathway gets activated, it essentially is going to result in that drug-seeking behavior. So we'll talk about some methods, both pharmacologically and behaviorally, that individuals use to mitigate the addictive response. But again, it's I think most advantageous when you do both the pharmacological intervention as well as the behavioral. I'm going to pause for a second because I have presented a few slides. Does anybody have any questions? And like always, feel free, if you don't want to speak up or unmic, you can always pop it up in the chat as well. Okay. So as we've been talking about kind of these different pathways, so we talked about how the ventral tegmental area is so important for the addictive pathway to kind of be generated. This is, again, a nice image because it's connecting several different locations in the brain that are important for both dopaminergic neurotransmission, as well as there is some GABAergic neurotransmission and some glutamatergic neurotransmission projecting to each. And so here you can see the red projections are going to be the dopamine projections from the ventral tegmental area, or the VTA, to the medial prefrontal cortex, or the nucleus accumbens, as well as the basolateral amygdala. So again, each one of these regions kind of gets activated under different types of circumstances. Your prefrontal cortex is obviously going to be very important for decision making. So when we're looking at individuals who are exhibiting drug-seeking behaviors, part of that is going to be that drug-seeking, that decision to the decision process of the drug-seeking behavior. Again, something worth kind of mentioning here, the hippocampus is also sending projections to these regions, to the nucleus accumbens. And again, the hippocampus is an area of the brain essentially where the molecular mechanisms for learning and memory occur. And so it's not surprising that a lot of the memory portion of this response is most likely mitigated by the hippocampal projection. Again, as we're looking through these different types of projections, there are both D1 and D2 dopamine receptors that are being activated in each one of these regions. But again, it's just kind of a well-worn path that once it gets activated, that seeking behavior kind of gets ignited once again. So in terms of kind of what causes that triggering, or that what increases that addiction propensity. And so there are a lot of different variables. So you can't necessarily just say, okay, this person has a genetic predisposition for, an addictive behavior. We've, we talked about that a little bit when we were talking, I think, about alcohol dependence. But really it's again, a whole variety of things that has to happen, right? So you have your, we'll talk first about your host or your user. Again, heredity, there can be some addiction propensity based off of certain, mutations in individuals, innate tolerance. We'll talk about the speed developing acquired tolerance, likelihood of experiencing intoxication, metabolism of drug. Again, that can be varied depending on your background, psychiatric symptoms, prior experience and expectations, and propensity for risk-taking behavior, which again can be either a genetic or an environmental kind of, impact or experience. Now, along with the host or the user, you also have the drug itself, right? You have the availability of the drug. How easy is it for a person to essentially find or achieve or obtain the drug, the costs, the purity and the potency of the drug, and then also mode of administration plays a role as well in terms of impacting propensity. You can see here kind of the whole slew of different ways in which drugs can be administered, and then the onset onset and termination effects. So the pharmacokinetics and the combination, which is essentially a combination of both the agent and the host. And then lastly, as we're talking about addiction, we're talking about its the role of memory in addiction. Obviously, having certain environmental triggers is going to play a huge role in that I guess relapse to a certain extent of addictive behaviors. And so things like social setting, community attitudes, availability to other reinforcers, pleasure, or recreation. So essentially, if you can almost take that dopamine that you originally were kind of addicted to and find, secondary sources of that. So again, your brain doesn't necessarily always differentiate between how it's getting that dopamine, but if it can get that dopamine, it's going to be very happy about it. So employment or educational opportunities and conditioned stimuli. So environmental cues become associated with drugs after repeated use in the same environment. So if you go back to that environment, most likely you're kind of setting yourself up for a relapse. And I keep saying you, but I mean, that's kind of the hypothetical use. So a user who has, who puts themselves into a situation that they have been repeatedly using in the past, that's going to be considered almost an environmental trigger. So when we talk about different drugs of abuse, you can see kind of the classification here. Things like the opioids, the cannabinoids, GHB, LSD, and drugs that bind to, those are all of the G protein coupled receptor, essentially agonists or agonists for either the opioid receptor, the CB1 receptor, the GABA B receptor, and the 5-HT receptor, the 2A receptor. Those are all either strong agonists or partial agonists, as you can see there. You can see that essentially the effect of the dopamine neurons is essentially disinhibition. So that disinhibition leads to almost an excitation or activation of the dopamine receptors. The second kind of section there, you can see that there are drugs that bind to the ionotropic and ion channels. So nicotine, alcohol, benzodiazepines, ketamine are all binding to ionotropic receptors. And if we go back and think about ionotropic receptors, that's going to be a very quick and fast response where you have either an antagonist or a positive modulator or an agonist binding to that receptor, causing some type of effect to that ion channel opening and either causing activation or inhibition of your new neurotransmitter. What's interesting to know when we talk about these ionotropic receptors, that you can have both excitation or disinhibition, kind of just depending on where that particular receptor is expressed within the activation or the addictive pathways that we're talking about, because obviously there are going to be some portions of that pathway that are going to become activated and that causes a positive side effect. And then there are going to be other parts of that pathway that are maybe trying to inhibit that pathway. If you disinhibit them, that's again going to cause essentially a kind of a rising or an activation, not directly though, to that particular signaling system. Last thing, I guess, section here that we can discuss are things like cocaine, amphetamine, and ecstasy. They're either acting as an inhibitor or a reverse transporter. Many of these instances, you're essentially blocking the uptake of dopamine transport, prolonging the hang time of dopamine in the synapse, thus making it, able to bind to more dopamine receptors, causing more dopamine receptor activation, and ultimately, again, kind of feeding into that addictive pathway. I'm just going to pause again to see if anybody has any questions. Hi, Keith.
Hey, just draw people's attention in my view of things, especially to that line there where LSD is listed, and note effect on dopamine neurons nil. We reasonably so associate tolerance and dependence with each other, but they don't always go together. And LSD is just the classic example in that regard, in which there's substantial development of tolerance, but not dependence. So I just wanted to emphasize that.
And LSD would be acting more through the serotonergic system. Am I correct? I think so. Yeah. Keith? Okay, yeah, so I mean, I guess that's possibly part of the non-dependent part of it, is that you're hitting a different neurotransmitter system. Okay, so that kind of, I guess, is a great segue to this particular slide, talking about non-addictive drugs of abuse. So some of these drugs that cause, alterations in perception and sensation, you're not necessarily seeing that same dopaminergic kind of pathway being activated. So if we look at the example of LSD, it's activating the serotonergic 5-HT2A receptors in the prefrontal cortex, enhancing glutamatergic transmission to those pyramidal neurons, and altering essentially, again, perceptions, leading to hallucinations and dissociative states. You can see here that the primary targets are going to be both the cortical and thalamic circuits. And then the example 1 is LSD. Example 2 is going to be ketamine. Again, ketamine is activating a different neurotransmitter system. You're hitting your NMDA type receptors. You're getting kind of that, again, euphoric state with ketamine. It's use-dependent inhibition of glutamate receptors. Again, you're not seeing the same types of addictive behaviors for LSD and ketamine. Not to say that can't exist, but I think the rates of incidences for those are far lower, and I think that has a lot to do with the different neurotransmitter systems that are being activated. So in terms of treatment, so as I kind of alluded to, a lot of the treatment is, multifaceted. You want to do some pharmacological treatment, obviously behavioral treatment as well, because we talk about how important environment and situation is to kind of triggering these addictive behaviors. And so ensuring that the individual kind of understands that, and also tries to avoid those environmental triggers as much as possible. So the objectives of addiction treatment is to help the individual stop using drugs, help maintain a drug-free lifestyle, and achieve functioning in work, family, and in social settings. So medication, we'll talk about some of the different medications that are prescribed to mitigate some of the withdrawal symptoms of drugs of abuse, help reestablish normal brain function, and prevent this essentially relapse and diminish the cravings. Again, it's a lot of that has to do more with dependence, and then also behavioral treatment. So modification of attitudes and behaviors related to drug abuse, and again, mitigating any type of environmental triggers that might be desired or required of the individual. So I've also included a link here just talking about treatments for approaches to drug addiction if you are in fact interested in it. So I guess it's worth kind of starting this off by talking about some of the treatments for things like opioids. You've probably heard of the opioid epidemic. And so when we're talking about the opioids, I think, you can talk about the whole range of use and the way the opioids are utilized. You have, at your one extreme, maybe heroin, and then you can also kind of think about even prescribed drug opioid abuse as well. We talks about things like oxycodone. So when we talk about opioids and some of the drugs that can be used to kind of assist in the withdrawal, methadone, buprenorphine, and naltrexone are all going to be possible uses. Again, when we're talking about this tapering off of dependence, it's differences. You can see here the example of the differences in responses to both heroin and methadone. So with heroin, you have that immediate kind of high and sick feeling. You're basically kind of running between those two, the highs and lows of that exposure. You can see here kind of the peak time of that is essentially every 6 hours. So that person might seek out to use roughly within that period of time. Now, in terms of treatment, methadone assists in the stabilization of that exposure, again, of the activation of the mu receptors. You can see here at the very bottom of this particular figure, the activation of the opioid receptor, mu opioid receptor, and that's again going to cause reinforcement and drug dependence. If we look at the active or the usage of bupropion, you have the mu partial antagonism. And so because of that, you can essentially antagonize the receptor and essentially block that interaction to a certain extent. And naltrexone, if you see, you can also see antagonism of that mu opioid receptor as well there. Again, if you're antagonizing that receptor, the agonist, the presence of the opioid can't bind to that receptor and cause essentially the downstream effects that the seeker is looking to use. I guess something, again, worth kind of noting here is to not necessarily just stop or to prevent use. Initially, if you can pharmacologically almost taper off that physiological dependence to that activation of that receptor, it bodes much better for that individual because you're not causing a huge shift in the physiological activation of the particular pathway within that individual. So here again are just some kind of additional kind of notes to be made. If you're interested in kind of the naltrexone, there's a particular article here that might be kind of interest to you. The Narcan treatment of overdose by police was administered in 2014, and now it's over the counter in 46 states. So again, in terms of ways to mitigate part of the opioid epidemic. Oof. Not quite sure why opioid is so difficult to say today, so I apologize. So again, kind of working our way through some of the highly addictive chemicals that we see probably the most frequently. Tobacco, again, is going to be a highly addictive agonist for the nicotinic receptor. And so here you can see part of the pharmacological approach to mitigating nicotine addiction. So bupropion, here you can see the activation of nicotine to receptors, activating those receptors, you can see rapid burst firing and essentially dopamine that's being released. And so if we have the second drug that we can see here, varenicline, you can see that it is going to block, it's going to act as an antagonist to those nicotinic receptors, essentially mitigate some of the dopaminergic response or release that we see there. Nicotine is a highly addictive agonist for the nicotinic receptors. I think roughly 70% or 80% of individuals who ingest nicotine try to quit each year, and roughly only 5% can quit in an unaided fashion. So often individuals who are seeking out cessation of nicotine are looking at some of these treatments that we're showing here. Okay. Okay. So this is, I guess, kind of a review slide for many of you. We've talked about alcohol, the effects of alcohol addiction and dependence. And so we've talked about these different drugs, naltrexone and cambrazate, as well as disulfiram and topiramate. So disulfiram specifically, we spoke about kind of at length, talking about how it interferes with the enzymes that are important for the metabolism of alcohol. Topiramate is going to be an anticonvulsant, which enhances GABA neurotransmission. And if we remember where ethanol binds to, ethanol is going to in fact bind to GABA receptors. So again, this is one way in which you can use the pharmacology to activate some of the same receptor pathways that you would see upon ingestment of these specific agonists. And then if you can kind of mimic that using some of these less addictive forms of that, it can really help mitigate some of the negative side effects that are seen during the withdrawal time period. Again, it's best to do that withdrawal exposure of the pharmacological agent that you're using to replace over an extended period of time, and reduce dosage over time as well. Let's see. So again, this is just a quick review showing you some of the pharmacological binding sites of the GABA receptor. We can see that benzodiazepine site as well as that GABA site. Again, it's going to also have that ethanol binding site. And so if you activate that GABA receptor, you're mimicking some of the effects of ethanol, but you can do so, again, in a more controlled fashion than what you're seeing with just upon ethanol consumption. So I'm going to pause for a second and ask, are there any questions or concerns at this time about this material? Keith?
Just to remind everybody, you probably don't need the reminder, but tomorrow is Veterans Day. And so it's a holiday, and therefore we miss our usual double header in pharmacology. I'm sure people are pretty broken up about that. But anyway, we'll be back in the saddle again on Thursday. I'll pick up there with continuation on our discussion of opioid drugs, and then on into antidepressants, and then finally a final segment on toxicology to conclude the course. So many thanks to all the veterans out there for your tremendous service to all of us, and we're very much appreciative of that. And I'll step back now, so if anybody has any questions. But anyway, just wanted to remind everybody about our holiday tomorrow. Thank you.
Yeah, I guess the only other announcement that I have is that I'm looking forward to getting the results of your exams hopefully this afternoon. I'll be putting those into Moodle, so you have access to that. And if everyone has taken the exam, then I'll be handing back your paper exams hopefully by the end of the day, if not today, I guess not tomorrow, probably on Thursday. Does anybody again have any questions or concerns about the exam, about the material today? This is actually going to be my last lecture in Pharm Talks. So I appreciate everyone's attention and time over the course of the semester. This is my first semester at the University of Montana, so I appreciate getting to know all of you. And again, if you have any feedback that you'd like to share with me, kind of, I guess a little less formally than the write-up that you'll be doing, I'd be happy to hear it. So thank you again for everyone's time today. And that's, I think, all I have for you, unless Keith, you have any final parting words?
No, just to jump in and thank you for your great lectures and involvement in the course, Katie. And you've enriched the course tremendously. So thank you very, very much.
I'm not going away entirely, but again, thank you all so much for your time and your patience. So that's all I have. Everyone have a wonderful day, and we'll see you on Thursday.
Thank you.